It kills 100,000 people a year. Yet, the symptoms can be as subtle as mild anxiety or a nagging cough. For decades, the moment a doctor suspected a pulmonary embolism, or PE, the response was automatic. Admit the patient, start heparin, and brace for the worst. But that binary approach is dead. Today, we are witnessing a massive paradigm shift in how we handle the blood clot crisis.
That is right. We have moved from a one-size-fits-all model to a precision spectrum. On one end, we have high-tech robots using ultrasound waves to dissolve clots inside the heart. On the other end, we have patients with confirmed PEs being sent home from the ER the very same day. The question is no longer just, is there a clot? The question is now, which protocol will save their life, and which one will save their quality of life?
Welcome to our deep dive on acute pulmonary embolism. We are synthesizing the gold standards from the 2019 European Society of Cardiology Guidelines, the 2018 American Society of Hematology Recommendations, and the latest data from the Pulmonary Embolism Response Team Consortium. We are going to build the modern clinical pathway, from the first moment of suspicion to the long-ignored aftermath of post-PE syndrome.
Let's start with the physiology. To catch a killer that mimics everything from a panic attack to pneumonia, you have to understand the root cause. It almost always comes back to Virchow's triad. You need stasis, which is slowed blood flow, endothelial injury, which is damage to the vessel wall, and hypercoagulability, a tendency for the blood to clot too easily.
And while we often think of the classic post-surgery patient, the modern risk profile is broader. We are looking at genetic factors like factor V Leiden or prothrombin gene mutations, but also acquired risks like active cancer, pregnancy, and even just long-haul travel. The clot typically forms in the deep veins of the leg, a DVT, and travels up to the lungs. Once it lodges there, it creates a ventilation-perfusion mismatch. The lung is breathing, but the blood isn't getting there to pick up the oxygen.
That leads us to the most critical phase, the diagnostic funnel. The biggest mistake clinicians make is over-testing low-risk patients and under-testing high-risk ones. You cannot just order a CT scan on everyone with chest pain. You have to filter them first.
Exactly. The literature is crystal clear. You must determine pre-test probability. We use scoring systems like the Wells score or the revised Geneva score. If a patient scores low, you do not jump to imaging. You use the PERC rule, the pulmonary embolism rule-out criteria. If a low-risk patient meets all 8 criteria of the PERC rule, like being under 50, heart rate under 100, and oxygen saturation over 94%, you can stop. You have ruled out PE without a single drop of blood or millisievert of radiation.
But what if they don't pass the PERC rule? That is where the D-dimer comes in. But here is the category king insight that many miss. D-dimer isn't just a positive or negative test anymore. The 2019 guidelines strongly advocate for age-adjusted D-dimer cutoffs. For patients over 50, you multiply their age by 10. A 70-year-old patient typically has a higher baseline D-dimer, so their cutoff shouldn't be 500, it should be 700. This simple math saves thousands of elderly patients from unnecessary CT scans.
If the D-dimer is positive or the pre-test probability is high, we move to the gold standard, CT pulmonary angiography. It allows us to visualize the clot directly. However, we have to mention the outlier we found in the research, the blue protocol. In skilled hands, bedside lung ultrasound can identify a PE by looking for specific profiles, like the A profile combined with a DVT or subpleural consolidations. It is a radiation-free alternative that is changing the game in the ICU.
So you have diagnosed the PE. This is where the old way of thinking ends. In the past, a PE diagnosis meant automatic admission. Now, we have to risk stratify. Think of it like a traffic light system.
Red light means high risk. This patient is hemodynamically unstable. They have low blood pressure, shock, or cardiac arrest. The clot is massive, and the right ventricle of the heart is failing because it can't push blood past the blockage. These patients need immediate reperfusion, systemic thrombolysis, or surgery.
Yellow light is intermediate risk. Their blood pressure is normal, but the heart is struggling. On an echo or CT, you see the right ventricle ballooning out. The RV to LV ratio is greater than 0.9. Their troponin levels are elevated, indicating heart strain. These patients are the most dangerous because they look stable, but they can crash at any moment. They need hospital monitoring and anticoagulation, but usually not full-blown thrombolysis, unless they deteriorate.
And then, the green light. This is the paradigm shift. These are low-risk patients. Their heart is fine, their blood pressure is fine. We use the Hestia criteria or the simplified PESI score to identify them. If a patient meets the Hestia criteria, meaning they are stable, not at high bleeding risk, and have social support, they don't need to be in a hospital bed. They can be treated at home with direct oral anticoagulants, or DOACs, like apixaban or rivaroxaban.
This is revolutionary. The Hestia criteria allow us to ask practical questions. Does the patient need oxygen? Are they in severe pain? Is there a social reason to admit them? If the answer is no, sending them home is not just cheaper, it's safe.
Now, let's talk about the patients who are stuck in that dangerous yellow light zone, the intermediate high-risk group. This is where we prevent the dip in outcomes. We have seen the rise of PERT, pulmonary embolism response teams. This is a squad of specialists, cardiologists, pulmonologists, surgeons, and interventionalists who convene instantly to decide the best move.
And often, that move involves advanced technology. We aren't just relying on systemic TPA, which carries a risk of bleeding in the brain. We are seeing a surge in catheter-directed thrombolysis, specifically devices like the EKOS system.
For those who haven't seen it, EKOS is incredible. It uses a catheter threaded right into the pulmonary artery. It emits ultrasonic waves that physically loosen the fibrin strands of the clot, allowing the thrombolytic drug to penetrate deeper. This means you can use a fraction of the drug dose, sometimes a quarter of the systemic dose, which significantly lowers the bleeding risk while still relieving the strain on the right heart.
It is precision medicine for a mechanical problem. But our job isn't done when the clot dissolves. This brings us to the blue ocean gap in our analysis, the aftermath. Most videos and textbooks stop at discharge, but the data shows that survival is just the first step.
That's right. We need to talk about post-PE syndrome. Research indicates that roughly half of all PE survivors report persistent shortness of breath, exercise intolerance, or functional limitations months after the event. This isn't just deconditioning. It's a physiological sequela that is often ignored.
There is a specific condition called CTEPH, chronic thromboembolic pulmonary hypertension. In about 2 to 4% of survivors, the clot doesn't dissolve. It turns into scar tissue, permanently narrowing the arteries and raising the pressure in the lungs. This leads to right heart failure and death if untreated.
And because the symptoms are just shortness of breath, patients are often misdiagnosed with asthma or anxiety. This is why we need to implement the search algorithm for follow-up. If a patient is still breathless 3 months post-PE, do not just refill their inhaler. Screen them.
The search algorithm is comprehensive. Check symptoms, exercise capacity, arterial perfusion, resting heart function, confirmatory imaging, and hemodynamics. If you find CTEPH, it is actually curable. A surgery called pulmonary endarterectomy can strip that scar tissue out of the arteries and restore normal function.
So let's bring it all together. The modern management of pulmonary embolism is a life cycle approach. It starts with a smart diagnosis using age-adjusted D-dimer and the PERC rule to avoid overtesting.
It moves to precise risk stratification. We identify the high-risk patients who need PERT teams and catheter interventions, and we identify the low-risk patients who can safely recover at home using the Hestia criteria.
And finally, we don't abandon them at discharge. We monitor for post-PE syndrome and CTEPH to ensure that surviving the clot doesn't mean living with permanent disability.
Medicine is moving fast. From ultrasound-facilitated catheters to home-based care, we have more tools than ever. It's up to us to use them correctly.
Thanks for joining us on this deep dive. Stay curious, and we will see you in the next one.